Hello, welcome to Anatomy DAHAR series. Today's topic is brachial plexus part 2, fine points and clinical aspects. It includes relations of each part of the brachial plexus, causes and clinical features of the brachial plexus lesions, postfixed and cervical rib syndrome, pathways of the cervical sympathetic fibers, stellate ganglion and nerve fibers through it, and Horner syndrome. Illustrated, prepared and presented by Dr. Abdul Hamid, Abdul Rashid. Brachial plexus, fine points and clinical aspects. Summary of the brachial plexus, recalled. The brachial plexus consists of 5 parts: roots, trunks, divisions, cords, and branches of the brachial plexus. Roots. 5 roots of the brachial plexus are formed by ventral rami of cervical 5, cervical 6, cervical 7, cervical 8, and first thoracic nerve. They unite to form 3 trunks. The upper 2 roots, that is C5 and C6, unite to form the upper trunk. The lower 2 roots, C8 and T1, unite to form the lower trunk. The middle C7 remain alone as the middle trunk. Each trunk bifurcates, that is splits into 2 divisions, anterior division and posterior division. Anterior division label A, posterior division label B. So if you see, there will be 3 anterior divisions and 3 posterior divisions, altogether 6 divisions. Formations of brachial plexus, continuation. Here we have 6 divisions, 3 anterior blue color and 3 posterior divisions. They continue laterally to form 3 cords. All 3 posterior divisions, this purple color, join to form the posterior cord. Out of 3 anterior divisions, upper 2 anterior divisions, this 2 blue color, join to form lateral cord. The lowest anterior division remain alone and continues as medial cord. So 3 cords are formed: lateral, posterior and medial. Erb's point. What is Erb's point? It is the upper trunk of the brachial plexus. It is short, where 6 nerves meet at this point. What are the 6 nerves? 2 roots you see here, anterior rami of cervical 5 and cervical 6 unite to form the upper trunk, which splits into anterior and posterior divisions, and upper trunk gives 2 nerves, that is number 1 suprascapular nerve and number 2 nerve to subclavius. So at this point 1, 2, 3, 4, 5 and 6 nerves will meet, and this point is called the Erb's point. It is the upper trunk of the brachial plexus. Location and relations of each part of the brachial plexus. We have 2 diagrams here. This is right lateral view of cervical vertebrae, first rib and the second rib. This is superior view of first and second right ribs. We are going to show structures attached and related to these structures. In diagram A, you can see here, these are the transverse processes of the cervical vertebrae. In the first rib, there's a small tubercle there called scalene tubercle, and this is the second rib. In diagram B, we are looking from above. This is first rib and this is second rib. Here is the scalene tubercle. This is the one where scalenus anterior muscles is attached. In front, there is one groove, and behind this scalene tubercle, there is another groove is there. Behind that is an area attached by scalenus medius muscle. And the third muscle, scalenus posterior muscles, is attached to the second rib. So let's see what are the structures related in the groove anterior to the scalenus anterior and posterior to the scalenus anterior. In the anterior group, the most anterior one is the subclavian vein, and between this vein and the scalenus anterior muscle is prevertebral fascia. Behind this scalenus anterior, in this groove, we have subclavian artery. Behind it is the lower trunk of the brachial plexus. It is important. This is the diagram of a typical cervical vertebra and right cervical nerve. We are looking from above, superior view. What is the most important criteria of cervical vertebrae? All 7 cervical vertebrae consist of foramen transversarum. This is body, and this is vertebral canal, and this is spine. Vertebral canal occupies the spinal cord. This is transverse processes. This is right, this is left. Each transverse process consists of anterior tubercle and posterior tubercle. What are the muscles here? This is in front of the vertebrae. You can see longus colli muscle. This is the one of the prevertebral muscles. On lateral side, anterior tubercle where scalenus anterior muscle originates, and posterior tubercle where scalenus medius muscle originates. So now look at the spinal cord. Each segment of the spinal cord gives a pair of spinal nerve, right and left. This is the right side. Each spinal nerve begins with 2 roots. This is anterior or ventral root. This is posterior or dorsal root. Dorsal root of the spinal nerve consists of dorsal root ganglia. These 2 roots of the spinal nerve join and form trunk of the spinal nerve. This will split or divide into 2 branches. The one behind this posterior or dorsal ramus, and this is anterior or ventral ramus of the spinal nerve. This ventral ramus of the spinal nerve, which forms the root of the brachial plexus. Which nerve? That is ventral rami of C5, C6, C7, C8, T1 of the spinal nerve will form the 5 roots of the brachial plexus, which is deep to the scalenus anterior muscles, between it and the scalenus medius muscles. This C5 to T1 ventral rami of the spinal nerve forms the root of the brachial plexus. These 5 roots of the brachial plexus join and form 3 trunks of the brachial plexus. In this slide, we have 2 diagrams, diagram A and diagram B. Diagram A is the anterior view of the prevertebral muscles. Diagram B is right lateral view of the prevertebral muscles. This is cervical vertebrae. and these are the prevertebral muscles. Before this, I have already shown you two diagrams. One is superior view of the first ribs and structures related, and the second one is cervical vertebra seen from above. There I have already mentioned the relations of the upper surface of the first rib and the structures, the muscles related to the cervical vertebra. In the second diagram, that is the cervical vertebra, anterior to the body of the cervical vertebrae, you have one group of prevertebral muscles, that is longus colli, I mentioned there, and anterior tubercles of the transverse process is originated by scalenus anterior, and posterior tubercle is attached by scalenus medius muscles. In the previous slides of the superior view of the first ribs, I also mentioned clearly that here, anterior to the scalenus anterior muscle, there's a groove over the first rib crossed by subclavian vein. Behind, there is another groove is there crossed by subclavian artery. In this second slide, the same thing we are looking from right lateral side. This is first rib scalene tubercle attached by scalenus anterior muscles. In front, the groove is crossed by subclavian vein. Between the vein and the muscle is prevertebral fascia. Behind the scalenus anterior, that is this muscles, and between the scalenus medius, you can see another groove is there, which is crossed by the subclavian artery. So, behind the scalenus anterior, and that is between it and the scalenus medius, there is very important gap is there, which also I have already mentioned in the superior view of the cervical vertebra. Between the two tubercles, ventral rami of the cervical nerve are coming, that is C5 to T1 coming. I've already mentioned that. So I'm going to continue this slide with more detail in the next slides. This is the enlarged diagram shown in the previous slides. We are showing prevertebral muscles seen from the right side. This is scalenus anterior muscles. This is scalenus medius muscles. Both are attached to the first rib. Between them, there is a gap. Ventral rami of C5, C6, C7, C8, and T1 spinal nerves forms the roots of the brachial plexus. They unite to form three trunks of brachial plexus: the upper trunk, the middle trunk, and the lower trunk. They continue laterally through the gap between the scalenus anterior and scalenus medius muscle. The lower trunk is the one crosses directly above the first rib behind the subclavian artery. We have already shown this one in the superior view of the first rib relation. The middle and the upper trunk, are above the artery in the same gap. We are looking anterior view of the prevertebral muscles. This is longus colli muscles. This is scalenus anterior muscle, and this is scalenus medius muscle. Deep to the longus colli muscles, we have 5 roots of the brachial plexus formed by ventral rami of C5, C6, C7, C8, and T1. The upper two join to form the upper trunk of the brachial plexus. The lower two join to form the lower trunk of the brachial plexus. The middle one remain as the middle trunk. They run laterally deep to the scalenus anterior, that is between the scalenus anterior and scalenus medius. That is the gap there we have already mentioned. And then pass laterally, all three of them pass laterally at the upper part of the posterior triangle of the neck, and then now all three are behind, that is deep to the clavicle. Cervico-axillary junction. Look at the diagram. This is right axilla, armpit. This is upper opening of the right axilla. It is triangular in shape. This is clavicle, this is first rib, and this is scapula. So the upper opening of the axilla is bounded anteriorly by the clavicle, medially by the outer border of the first rib, and posteriorly by upper border of the scapula. This triangular area, the upper end of the axilla, is the junction between the neck and the axilla. Therefore, it is called cervico-axillary junction. Through this cervico-axillary junction, structures between the neck and axilla traverse. At the back of the clavicle, that is deep to the clavicle, that is at this cervico-axillary junction, three trunks of the brachial plexus divides or split into anterior and posterior divisions. So there will be 3 anterior divisions and 3 posterior divisions. A total of 6 divisions will be behind the clavicle. So there are 6 divisions of the brachial plexus deep to the clavicle, that is in cervico-axillary junction. So this 6th division, anterior 3 and posterior 3, will join and form 3 cords. All 3 posterior divisions, this purple color, join together and form posterior cords. Out of 3 anterior divisions, which are blue in color, the upper 2 anterior divisions join and form the lateral cord. The lowest anterior division alone will continue and form the medial cords. So from 6 divisions become 3 cords, and they will give branches. In the axilla, 3 cords embrace the axillary artery. This is right brachial plexus with right axillary artery and right axillary vein. This is posterior cord, this is lateral cord, and this is medial cord of the brachial plexus. Here the posterior cord is behind, the lateral cord is on the lateral, and medial cord is on the medial to the second part of the axillary artery, that is deep to the pectoris minor muscles. The extension of the prevertebral fascia in the neck surrounds the axillary artery and cords as an axillary sheath. Local anesthetics are injected into this axillary sheath to produce the brachial plexus nerve block. Brachial plexus block. 2 types. A. Supraclavicular anesthesia block of the brachial plexus. The subclavian artery is palpated at the midpoint of the clavicle, and the needle is inserted behind it. B. Axillary anesthesia block of the brachial plexus. It is blocked through the axilla. Lesions of the brachial plexus, that is brachial plexus nerve injury. Brachial plexus may be damaged by many causes, including gunshot or step injuries, trauma, automobile and motorbike accidents, falls from height, and forceps and breech deliveries, malignancy, and radiation for breast cancer. Total brachial plexus injury is very serious but rare. Injury to the lower roots of the brachial plexus may injure the preganglionic sympathetic fibers of T1, first thoracic nerve, leading to Horner's syndrome. See below. Upper trunk injury. This is the one, upper trunk. The upper trunk of the brachial plexus is formed by two roots, C5 and C6. It is the meeting point of 6 nerves and called Erb's points. What are the 6 nerves? These 6 nerves include C5 and C6, formed the upper trunk, which will divide or splits into anterior and posterior divisions, and this upper trunk will give 2 branches. Number 1, that is suprascapular nerve, and number 2, nerve to subclavius. So C5, C6, anterior division, posterior division, and suprascapular and nerve to subclavius, all 6 of them will meet at this point called Erb's points. It is already stated above. Upper trunk injury, Erb's palsy. We have 2 diagrams are there, A and B. This upper trunk injury, Erb's palsy, occurs often when the upper angle between the shoulder and the neck is abruptly widened and stretched. This is between the shoulder and neck is abruptly widened and stretched. It is common in the newborn during forceps delivery and when the baby's shoulder is difficult to come out, that is obstetrical palsy. You have a neck and shoulder become widened and stretched. It also occurs when falls on the shoulder. See here, shoulder and neck angle become widened and stretched. See arrow. Upper trunk or Abduction palsy. As the upper trunk is made up of the union of C5 and C6 nerve fibers, in its injury, the nerves that are mainly made up of C5 and C6 fibers are affected. What are the nerves chiefly or mainly made up of C5 and C6? They are suprascapular nerve, nerve to subclavius, musculocutaneous nerve, axillary nerve, subscapular, upper and lower subscapular nerves. So when these nerve fibers are affected, which muscle will become paralyzed or affected? Because of suprascapular nerve, the muscle affected will be supraspinatus and infraspinatus muscles. Because of nerve to subclavius, the muscle affected is subclavius muscles. For the muscles which is supplied by musculocutaneous nerve, when this nerve is affected, biceps brachii, coracobrachialis and brachialis muscle, that is in front of the arms, will be affected. If axillary nerve is affected, that means deltoid and teres minor muscle will be affected. Upper subscapular supply the subscapularis muscles. Lower subscapular supply the subscapularis muscles, and teres major muscles, they will be affected. Erb's palsy, that is upper trunk injury. Clinical features in UBS palsy on the affected sites are: number 1, loss of roundness of the shoulder. Loss of roundness of the shoulder due to paralysis of the deltoid. Number 2, loss of abduction of the arm due to paralysis of supraspinatus and the deltoid muscles. The upper limb is hanging down besides the body due to paralysis of the deltoid and rotator cuff muscles. What are the rotator cuff muscles? Supraspinatus, infraspinatus, teres minor, and subscapularis. The upper limb is rotated medially due to loss of functions of lateral rotator muscles. They are infraspinatus and teres minor. Number 5, the elbow is extended due to the loss of function of its flexor muscles. They are biceps brachii and brachialis. Number 6, the forearm is pronated due to loss of functions of one of the supinator muscle, that is biceps brachii. Number 7, loss of sensation at the upper lateral part of the arm, that is regimental area, due to loss of function of the upper lateral cutaneous nerve of the arm, which is the branch of axillary nerve. The upper limb on the affected site is held in a portus or waiters hinting at the tip, in which the arm is adducted and medially rotated, and the forearm is extended and pronated. We have two diagrams here, diagram A and diagram B. The topic is lower trunk injury, called Klumpke's palsy. The lower trunk of the brachial plexus is made up of C8 and T1 nerve fibers. It crossed over the first rib behind the axillary artery, already stated earlier. Injury to the lower trunk, Klumpke's palsy, often occurs when the lower angle between the arm and the trunk is abruptly widened and stretched, hyperabducted. Hyperabduction of the shoulder joint is common in the forceful pulling of the hand of the baby during delivery. See diagram A, pulling of the baby during birth. And catching the branch when falling from a tree. Look here, diagram B. Lower trunk injury is often occurs in postfix brachial plexus, stated in brachial plexus part 1, or the lower trunk is stretched in cervical rib syndrome, see below. May also occur in malignant infiltrations of the lower trunk, as in tumors of the lung or the breast, and enlargement of lower deep cervical lymph nodes. So, figure A and figure B shows the lower trunk injury because of the angle between the trunk and the shoulder arm is suddenly widened. Most of the intrinsic muscles of the hand, interosseous and medial to lumbricals, are supplied by C8 and T1 nerve fibers through the lower trunk. The functions of these muscles are flexion of the metacarpophalangeal joints, the extension of interphalangeal joints, and abduction and adduction of the fingers. These functions will be lost in the lesion of the lower trunk of the brachial plexus. Clinical features in Klumpke's palsy on the affected site. Number 1, hyperextension of metacarpophalangeal joints due to loss of function of the intrinsic muscles of the hand. Number 2, flexions of the interphalangeal joints called true claw hand. You can see here there's a hyperextensions of the metacarpophalangeal joints and flexions of the interphalangeal joints called true claw hands. Number 3, loss of function of abduction and adduction of the fingers. Thenar and hypothenar eminences become small and flat. Loss of adduction function of the thumb due to paralysis of adductor pollicis muscles. Loss of sensation along the medial surface of the arm because it is the area of the T1 dermatome. Postfixations of brachial plexus found in 10%. In postfix, the brachial plexus form one segment lower than usual. That is, usually it begins from C5 to D1, but in postfix it will begin from C6, C7, C8, D1 and D2, one segment going down. The contribution from D2 is larger now and C5 is reduced. In postfix, brachial plexus will have a mechanical disadvantage since the lower trunk has to be more angulated and hence stretched on the upper surface of the first rib. This is first rib. Because the whole plexus is going down, this lower trunk has to go around the first rib. So it will be stretched there. This may give rise to symptoms of compressions of the lower trunk. Cervical rib syndrome. Look at the diagram here. This is upper opening of the thoracic cage. This is C7 vertebra, cervical 7 vertebra. This is transverse process of the 7th cervical vertebra. This is first rib. Upper surface of the first rib is crossed by subclavian vein, subclavian artery, and the lower trunk. Now let's talk about the cervical rib. It is a rare condition where a calcified ligament or even a bony structure is attached between the transverse process of the C7 vertebra here and the upper surface of the first rib. So this cervical rib, which may be ligament or even the bone, attached between the transverse process of C7 vertebra and upper surface of the first rib. The cervical rib is often pressed on the lower trunk of the brachial plexus, which is made up of C8 and T1 nerves, and the subclavian artery, which accompanied the lower trunk. So this ligament, cervical rib, may press on the lower trunk together with the subclavian artery, producing neurological deficit and vascular insufficiency respectively as these structures cross over the first rib. Horner syndrome. What is Horner syndrome and how does it relate to the brachial plexus? Horner syndrome is a classic neurologic syndrome with 3 distinct clinical signs. It is caused by a lesion anywhere along the sympathetic pathway that supplies the eye, head, and neck. The cervical sympathetic pathway passes through the roots and trunks of the lower part of the brachial plexus. Lesions of this part of brachial plexus is one of the causes of the Horner syndrome. Prerequisites of Horner syndrome. The autonomic nervous system. The autonomic nervous system consists of two principal divisions, sympathetic and parasympathetic. They arise from the central nervous system, CNS, and consist of a sequence of two neurons between the central nervous system and innervated structures. The cell body of the first neuron is located in the central nervous system, that is in the spinal cord or in the brainstem, while that of the second neuron is located in the ganglia. The first neuron is before synapse at the ganglia, hence called Preganglionic neuron. It is myelinated and white in color. The second neuron is after synapse at the ganglia, the postganglionic neuron. It is unmyelinated and gray in color. This is the transverse section of a segment of the spinal cord. Look at the diagram. Each segment of the spinal cord consists of, number 1, a central canal, which is surrounded by, number 2, H-shaped gray matter. Outside that is number 3, white matter of the spinal cord. Each half of the gray matter has two horns throughout the spinal cord. Important. That means every segment of the spinal cord, gray matter has two horns. They are anterior or ventral horn and posterior or dorsal horns. Cell bodies of the motor neurons are located in the ventral horn. Cell body concerned with the sensory are located in the dorsal horn. However, segments of T1 to L2, that is the first thoracic segments to second lumbar segments, consist of additional horn on the lateral part of the gray matter, that is called lateral horn. The lateral horns from T1 to L2 segments is the locations of the cell body of preganglionic, that is first order sympathetic neurons located in the lateral horn. Sympathetic divisions of the autonomic nervous system. Let's see the diagram. These are the segments of the spinal cord. Each segment gives a pair of spinal nerve, one on each side. Each spinal nerve begins with the two roots. This is anterior or ventral root. This is posterior or dorsal roots. Dorsal roots consist of dorsal root ganglion. These two roots join together and form the trunk of the spinal nerve, which splits into posterior or dorsal ramus and anterior or ventral ramus. Sympathetic trunk or sympathetic chain. It consists of a pair of ganglionated chains called sympathetic trunks or sympathetic chains, lying one on each side of the vertebral column and anterior to the trunks of the spinal nerves. One on each side of the vertebral column and anterior to the trunks of the spinal nerve. Hence, it is also known as paravertebral sympathetic trunk or chain because on either side of the vertebral column. Each paravertebral sympathetic trunk or chain carries paravertebral sympathetic ganglia. They are 3 in the cervical region, 11 in the thoracic region, 4 in the lumbar region, and 4 in the sacral region, a total of 22 ganglia in each trunk or chain. The terminal single ganglion, the ganglion impar, is at where two trunks or chains diffuse below. So a total of 45 ganglia. 22 plus 22 plus 1, 45 ganglia. Sympathetic neurons. Neurons mean nerve cells. Sympathetic neurons mean nerve cells of the sympathetic nervous system. Let's see the diagram. This is a segment of the spinal cord. Consists of central canal surrounded by H-shaped gray matter. This is anterior horn and this is posterior horn on each half of the gray matter. This anterior and posterior horns of the gray matters are present in every segment throughout the spinal cord. However, from T1, that is the first thoracic, to L2, second lumbar segments, there is additional gray matter on the lateral side of the gray matter. This is called lateral horn of the spinal cord, which you will see only in first thoracic to second lumbar segments of the spinal cord, that is thoracolumbar part of the spinal cord. From each segment of the spinal cord, a pair of spinal nerves comes out. Each spinal nerve has two roots. This is ventral root number 1. This is dorsal root. These two roots join together and form number 2, trunk of the spinal nerve. And it splits into number 3, ventral ramus and dorsal ramus. From the ventral ramus, there is another branch comes out. This is the sympathetic trunk. This is sympathetic ganglia. So this branch is called white rami communicant. Connect the ventral ramus to the ganglia in the sympathetic chain. After this, between the disc ganglion and the trunk of the spinal nerve, there is another branch is there, that is gray rami communicant. These are the parts of the spinal nerve we are going to talk. As I have stated earlier, lateral horns are the place where cell bodies of the first order sympathetic neurons are located. I have already mentioned that. So now we are going to say about the sympathetic neurons. It consists of a series of two order neurons, first order neuron and second order neuron. The first order neuron is before its synapse in the ganglia, so it is also called preganglionic sympathetic neurons and fibers, which are myelinated and white color. After synapse, we call the second order neuron is postganglionic neurons, which are unmyelinated and gray in color. In the diagram, preganglionic sympathetic fibers are continuous line, postganglionic sympathetic fibers are interrupted line. So here you will see first order neurons. Cell body of the first order neurons are located at the lateral horn of the segments of the spinal cord. Then its nerve fibers will go along the number 1, ventral root of the spinal nerve, number 2, trunk of the spinal nerve, number 3, ventral ramus of the spinal nerve, and then from there it continues through the white rami communicant to reach to the sympathetic ganglion along the sympathetic chain. This is the segments of the spinal cord. This is cell body of the first order neuron, that is preganglionic fibers, myelinated and white. This preganglionic fibers comes along the ventral root, trunk, and then white rami communicant and reach to the paravertebral ganglia along the sympathetic trunk. Once preganglionic fibers reach to the paravertebral ganglia in the sympathetic trunk, they are distributed as follows. Number 1. Some preganglionic fibers synapse with the cell body of postganglionic, that is second-order neurons in the paravertebral ganglia of its respective level in the sympathetic trunk. So once these preganglionic fibers reach to the ganglia, some fibers will synapse with the cell body of the postganglionic neuron. This is the second-order neuron. So the postganglionic sympathetic fibers, which is unmyelinated gray fibers, will leave the ganglion through the gray rami communicants back into the respective spinal nerve and distributed through the branches to supply the blood vessels, sweat glands, and erectile pili muscles of the skin. In the second group, some preganglionic fibers, once reach to the paravertebral ganglia, sympathetic ganglion, they do not synapse there. Some of the fibers ascend along the sympathetic trunk to the cervical region. Some will descend to the lumbar region. Then those who ascend to the cervical region will synapse at the cervical sympathetic ganglion, and the one descend to the lumbar region, they will synapse at the sympathetic ganglion at the lumbar region. In both regions, the postganglionic fibers leave the ganglion through the gray rami communicants and enter the spinal nerve of the corresponding level and are distributed through the branches. Note, in both regions above and below, there are gray rami communicants only and no white rami communicants. Because, as you know from the very beginning, the white rami communicants are coming from the neurons which are in the T1 to L2 levels of the spinal cords only. In the third group, if you see here, look very simple. Here is the first order neuron. This is coming continuous line. These are myelinated fibers and not synapse yet, white in color. So these fibers, first order neuron fibers, after coming along the root and trunk and ventral ramus and white rami communicant, once reach the ganglia, not synapse, not go up, not go down, but go through this ganglia and go through the splenic nerves here. Here is aorta. In front of the vertebra, we have second neuron is here. The ganglion is there. This is in front of the vertebra, we call prevertebral ganglion is there. Here, this continuous line, preganglionic first order fibers, synapse, and this is the postganglionic fibers, dotted line, comes out and supply the viscera, the organs. The fourth group follows exactly like the third group. Here is the cell body of the first order neuron. This is preganglionic fibers, white in color, myelinated, going through the anterior root and trunk of and ventral ramus of the spinal nerve, and now go through the white rami communicant. Once reach to the ganglia along the sympathetic chain, not following the first pattern, not synapse there, not following the second pattern, not going up, not going down, but it goes through the nerve here, which is still continuous line, that is preganglionic fibers, and go direct to the suprarenal gland. adrenal glands is there. It will go directly to the suprarenal glands is there. In the suprarenal glands, they synapse with chromaffin cells of the adrenal medulla. These cells are functionally equivalent to the postganglionic neurons of the sympathetic nervous system. So there is no second order neuron ganglion is there, but these first order neuron will go direct to the suprarenal glands and there synapse with the cells, chromaffin cells of the adrenal medulla, which serves as the postganglionic neurons. Cervical sympathetic ganglia. I have already presented that there are three large ganglia along the cervical part of the sympathetic trunk. They are superior, middle, and inferior cervical sympathetic ganglia. Look at the diagram again. This is the segments of the spinal cord. Pre-ganglionic sympathetic fibers. Look here, pre-ganglionic sympathetic fibers coming from the T1 to T4 segments of the spinal cord after passing through the paravertebral ganglia here without synapsing. No stop there. Without synapsing, the fibers, these preganglionic fibers, ascend along the track and they will synapse, some at the superior ganglion, some at the middle ganglion, and some at the inferior ganglion with the second order neurons, that is the postganglionic neurons. They will synapse here. Cervical sympathetic ganglia continuations. I have already mentioned there are three cervical sympathetic ganglia in the cervical region. This is inferior ganglion, middle ganglion, and superior ganglion. This is preganglionic sympathetic fibers coming from here and then go along, reach to the paravertebral ganglion in the sympathetic chain, but without synapsing, without going to any other place. It ascends along the sympathetic chain into the cervical region, and some will synapse in the inferior ganglion, some within the middle ganglion, some in the superior ganglion with the postganglionic neurons. Okay, in the superior cervical ganglion, number 1, it is the largest and is formed by the fusion of upper 4 small cervical ganglia. It gives postganglionic gray rami communicants to the ventral rami of C1 to C4 cervical spinal nerves. Next is the middle cervical ganglion, number 2, is formed by the fusion of 5th and 6th small cervical ganglia. Here it will synapse with the postganglionic neurons and postganglionic fibers will enter into the 5th and 6th cervical spinal nerves. Here in the inferior ganglia, the synapse with the postganglion. Here, this postganglionic fiber, gray rami fibers, will enter into the C7 and C8 spinal nerves. In addition to it, what is more important is in this cervical sympathetic trunk, there is additional fibers. Very important, that is preganglionic sympathetic fibers coming directly from the first thoracic segments of the spinal cord. So from the first thoracic segments of the spinal cord, there is the preganglionic fibers is here. It comes along here and goes up along this cervical sympathetic chain together with other fibers. So this fibers coming from T1 is very, very important for Horner syndrome. So you know that in the cervical part of the sympathetic chain, we have 3 sympathetic ganglia: superior, middle, and inferior cervical sympathetic ganglia. Below this, you can see here there is another ganglion. It is coming from here. This is the T1, first segment of the thoracic part of the spinal cord, and it also gives the sympathetic fibers coming here along this one and comes to here. So what happened is these 2 ganglia, inferior cervical sympathetic and the first thoracic T1 ganglia, fuse together and form big star-shaped ganglia called stellate ganglia. So the fibers coming from here, this is the preganglionic fibers, sympathetic fibers. After coming through here, it enters into the stellate ganglion but doesn't synapse here. The fibers will go up, ascend up to the superior cervical sympathetic ganglion, and only here it synapses and gives the postganglionic unmyelinated fibers, which is coming from continuation from T1. Okay, so this postganglionic fibers coming from T1 supply to many structures, 5 structures. What are they? First is dilator muscles of the pupil, number 1. The second is smooth muscles of the upper eyelid called Muller's muscle. Number 3 is vasomotor fibers supplying to the vessels. And number 4, pseudomotor fibers to the sweat glands. Number 5, pilomotor fibers to the erectile muscles of the hair, of the skin, of the head and face. So these 5 structures are supplied by postganglionic fibers coming from T1. So what you have to remember here is, as you know, T1 fibers will form the lower part of the root of the brachial plexus. If this pathway is injured, then which will be affecting the lesions of the brachial plexus. We will continue next. In traumatic injury to the roots of the lower part of the brachial plexus, T1 spinal nerve will be involved because this is one of the root in the brachial plexus. Therefore, preganglionic white ramus communicants of T1 is commonly damaged, which supplies 5 structures of head stated in the previous slide, which may give rise to the symptoms associated with loss of sympathetic supply to the eye, face, and neck called Horner syndrome. It may also occur in lesions of the brainstem, cervical part of the spinal cord, or stellate ganglia, which may give rise to symptoms associated with loss of sympathetic supply to the face, as in Horner syndrome. Characteristic features of Horner syndrome. We have a diagram of the faces there. Right half of the face is Horner syndrome side, that is on the right half. Left half of the face is normal. So what will happen on the right half of the face? Number 1, partial ptosis, slight drooping of the upper eyelid due to paralysis of the Muller muscles. You can see here upper eyelid is dropping a little bit lower than on the left side. This is a normal side. Number 2, meiosis, constriction of the pupil due to paralysis of dilator pupillae muscle, and unopposed action of sphincter pupillae. You can see pupil is much smaller than the normal side. Number 3, anhydrosis, loss of sweating. That means this side will be dry due to the involvement of pseudomotor fibers which are concerned with sweating. So on the normal side, you may see sweats are there, but on this Horner syndrome side, there is no sweating and it is dry. Number 4, flushing of the face due to involvement of the constrictor fibers leading to vasodilatation in the arteries of the skin of the face. So constrictor sympathetic fibers are not functioning, so the vessel will be dilated, vasodilatation, so there will be flushing, slightly red in color compared to the normal side. Number 5 is optomosis, sunken eyeball due to paralysis of orbitalis muscle. The end, illustrated and presented by Dr. Abdul Hamid, Abdul Rashid. Now is a good time to subscribe to our Anatomy DAHAR series channel. You will be notified as soon as our next video is available to you. Anatomy DAHAR series also provides other videos related to the present topic. Enjoy and thanks for watching.